manage your time effectively. Thank you very much, sir. Okay, let me start without further ado. Well, when we look at general clinical practice, we see that adherence is a problem, but especially in psychiatric problems, the use of antipsychotics always create a compliance issue. When we look at outpatients, we see that 80% of these patients have compliance difficulties, and only less than 50% of these patients during the first month after discharge is compliant, and within 2 years this goes down to 30%. And the clinicians wrongly assume that patient compliance is better than the actual numbers, so they are not very good at projecting the compliance numbers. So the biggest trial in that respect is KT trial. We see that within 18 months, nearly 74% of these patients discontinued their treatment. So this is for 1.5 years. And if you remember, the discontinuation levels were researched specifically, and in the best of conditions, 60% of the patients discontinue their medication. And sometimes they withdraw completely, sometimes they take drug one day and forget the next, and this increases hospitalization levels. And we have compliance issues in bipolar disorder. That's why we have more manic and depressive episodes. Why do we have poor compliance? Because in antipsychotics we have this biggest problem. In antidepressants there is a problem, and general medicines have lower compliance issues. First of all, lack of insight, complicated treatment regimes, and substance abuse and side effects, and poor symptom control are some of the reasons why patients discontinue their medication. In bipolar disorder, the efficacy and the side effects play an important role, but there is also a neurocognitive effect, because especially in manic phase or in the naive phase, these patients believe that they are more clear in cognition, they think more clearly, and they think that medication numbs them. Medication numbs their brain. So the artists who suffer from bipolar think that medication decreases their creativity. So therapeutic cooperation and psychoeducation is very important. Comorbid disorders, social support, and substance abuse also play an important role. When you administer depot, the compliance rates are a little bit better, but within years we again see higher discontinuation rates and higher rates of relapse. So there are certain decisive factors in compliance: the features of the drug, its efficacy, whether it's polypharmacy, the side effect profile, administration route, and lack of insight, personal features, and the level of therapeutic cooperation. Does the patient trust the clinician or not? Maybe this is where we can make the highest contribution, because the other factors we can control only indirectly, like family and social support. So when you look at NICE guideline, you see that there is more and more combined therapies with drugs and psychoeducation, especially in schizophrenia. Why? Because they are both effective, and if you want to alleviate the symptoms, drug needs to be supported by psychoeducation, and this increases the compliance levels. And if there is depression, insomnia, and anxiety, this could be decreased by pharmacotherapy, and this will increase the efficacy of psychoeducation. And people used to think that psychotic patients do not do well in psychoeducation, but this is not true for cognitive therapies. In bipolar disorder, when you look at treatment guidelines, you see that mood stabilizers should be used, and when it's necessary, we can use specific psychotherapies, or maybe we can have add-on therapies like antidepressants or anxiolytics. So which psychotherapies are effective? Interpersonal and social rhythm therapy can be used, or we can use CBT, we can use group or individual psychoeducation, and family therapy. Both in schizophrenia and bipolar disorder, these are add-on therapies. So we definitely have to use a drug, but the pharmacotherapy should be supported by psychotherapy. So does it affect compliance? This is by Lam et al. For bipolar patients. We see that the cognitive therapy increases compliance in bipolar patients. This is like a 12% positive effect. This shows the different effects of psychotherapies in bipolar disorder. Does it affect recurrence or relapse, or does it have an efficacy on symptoms? In summary, we can say that individual psychoeducation has an effect on recurrence and relapse, but doesn't have any efficacy on the symptoms. Cognitive therapy has an effect on relapse and recurrence, but it doesn't have any efficacy on manic symptoms, but it has an effect on depressive symptoms. And IPSRT is effective on all domains. So what can we do? How can we intervene? Of course, rather than what's going on around it, we have to try to tell the patient that perceptions and insights and interpretations are important. So the perspective, the beliefs, and the convictions of the patient should be learned. There are some myths, because the patient might think that, I'm not weak enough to take a drug. I should be getting better without any medication. These medications are drugs. They will control me. Or they're afraid of the efficacy of these drugs. Like, if I start taking this medication, I will be abusing this substance. I will become addicted to it. And if I take it for a long time, I'm going to have, my tolerance levels will go up, and it's not going to be effective in the long run. And if I start this, I won't be able to withdraw, and I'm feeling better, so I don't have to take any drugs. So the patients have selective attention towards the side effects. I had a patient once, and the side effects listed, and this also include infertility. I told the patient that it never caused infertility, but the patient said thalidomide caused a lot of birth defects, so maybe this drug will have some negative impact on me, the patient said. So they have a selective attention on certain side effects. And sometimes they generalize a lot. I used a medication before and it didn't work, so this drug is not going to work on me either. So they think, all these drugs are the same, and they personalize. My mother used a medication, it didn't help her. My aunt used it, it didn't help her. And sometimes they say, he used this medication and he died. And, they say, I shouldn't do this, I shouldn't get worse, I shouldn't use this drug, etc. And the patient sometimes thinks that they will be stigmatized. If they see me taking this drug, they will think I'm addicted to it, and if I get better, they will think it's only because of the medication. and sometimes they will not trust the physician. The physician thinks that I'm a guinea pig, I don't trust my physician, he doesn't know what he's doing, etc. And there are some wrong beliefs, a lack of insight. For example, some of the patients say that I have a real problem with my life, the drug cannot change it. Or if my illness is biological, then the drug cannot do anything to treat it. Nothing will change this course of disease. I would like to give an example here, especially regarding the side effects. The patients complain a lot. In our cognitive therapy sessions, we don't want to impose anything on the patient. We just want them to perceive and interpret something for themselves. This is the Socratic method. When they have complaints about side effects, this is the intervention I'm using. I ask this question to my patient. What is the substance when you take more than enough is going to impair your renal system, your heart system, and it's going to cause lung edema? It's water. If you ingest it more than necessary, these would be the side effects of water in the package insert. And I talk about water intoxication to the patient. So water intoxication is a real condition, and when you just ingest water without any minerals, in a couple of days your electrolyte levels will be disrupted and you will develop water intoxication. Or margarines. If they were sold as medicines, they would cause a lot of intoxication in our metabolism if they were consumed in higher amounts. That's all I have to say. Thank you very much. Thank you very much, Hakan, for keeping the time.